muscular, maybe fibrous stroma. And then I'll wait for it to be not so blurry. But overall, the cells, the nuclei are pretty uniform and dark, prominent nucleoli. I guess this sort of, so the diagnosis on this one is an adult granulosa cell tumor. And this one kind of looks like the either maybe like diffuse or trabecular subtype. And it's still a little blurry, but I know in some areas, oh, there's one right there. You can appreciate the coffee bean nuclei that are pretty typical of these kinds of tumors. And then in terms of evaluating this, we'd want a reticulin to be able to see that it's not enveloping the fascicles as it should be. Yeah.
Very good, very good. Yeah, so this is one of those sort of intermediate grade granulosa cell tumors without some of the more classic patterns. This sort of more spindly and vaguely lobular pattern is, I think, perhaps among the more challenging ones to reliably differentiate from other things. But if you were thinking of other possibilities, what would you think of here?
Mute myself.
What would be your differential diagnosis?
I think probably some sarcomas, just based on the appearance, because it's so spindled, whether it be an endometrial stromal or like a high-grade serous tumor, maybe.
Yeah, that's a great part of the differential. Would be an endometrial stromal sarcoma or a fibrosarcoma or a thecoma, a malignant thecoma, or something in that category. Potentially also maybe a poorly differentiated Sertoli-Leydig tumor.
Okay.
Could have a more sarcomatoid appearance like this as well, without a high degree of pleomorphism and so forth. And then immunostains, you mentioned the reticulin stain. Immunostains that may be helpful in sort of steering you away from, say, endometrial stromal sarcoma would be what?
Should be negative for ER and PR. And then this will be negative for EMA and positive for inhibin and calretinin.
Right, right.
That should steer us away from the ESS.
Okay, great. Anybody have any questions for Eleanor on this case? Okay, who's next on our list? I'm going to stop your share and share with, and let's go on to Carlos. Would you take case number 2?
Yes. Give me 1 second. I will open my. Yes. Okay. So. Yes. Can you see my screen?
Yes. Very good.
Okay. So we have this case. So in this one, we can see at low power these areas that is like a really well demarcated lesion that contrasts with the rest of the ovarian stroma that seems a little bit more normal. So in this area, we have cells that, well, their architecture is like a diffuse architecture where we can see these microfollicular pattern that are like in this circular arrangement, and that's all it's called the Kohl-Exner bodies. And also, if we go at higher power, this one I think we can see. I don't remember. I can see some nuclear groups, and some of them I remember, and prominent nucleoli. And so this one is, yes, I think there were some longitudinal groups in some of them. So this is also a adult granulosa cell tumor. And as you say, the differential diagnosis, the main differential diagnosis will be endometrioid adenocarcinoma with a sexual score, sex score differentiation.
So go back to low power, if you will, Carlos. There's one other area on this slide that looks a little different, and I'd like you to comment on that as well. You've done well with this. You're right. This is an adult granulosa cell tumor with a very classic Call-Exner body type appearance. But this area up here, what do you make of this area up here?
So in this area, we can see some a kind of nested pattern with trabecula in between, like fibrous trabecula, highly nice. So the cells, we have, some of them have clear cytoplasm, or some of them eosinophilic, but in general, they're like very regular nuclei, round and prominent nucleoli. So this one, it could be, I think could be, one of the differential could be Brenner tumor.
Okay.
Also, well, I think it seems like really a little bit big for that, but yeah, I think that's the main differential, because I think it seems like a little bit regular and well demarcated.
Yeah, so the key point is that this is not part of the granulosa cell tumor.
No.
And granulosa cell tumors are noted for having other components, like other associated lesions, like mucinous cystic lesions or other epithelial lesions. And so this could be, as you indicate, a Brenner tumor. It could also be a Hilar cell lesion, a steroid cell tumor with the very round nuclei and the vacuolated cytoplasm could fall into that category as well. So you don't always just stop once you get the first diagnosis. Sometimes with a Brenner, with a tumor of the granulosa cell or other lesions like this, you have to look a little bit further and make sure you haven't missed something.
Okay, yes.
Good. All right, so next up, let's see. Jordan, would you take on case number 3? Make sure you unmute your microphone so that we can hear you.
Okay, everyone can hear me now, right?
Right, very good.
Sorry, I had a bunch of food in my mouth and I was trying to clean my hands. Sorry about that. Okay, so everyone can see my screen and hear me, good deal. So from really low power, we see some areas that are more basophilic, as well as some areas that are very eosinophilic, like here. We have a lot of perhaps like cleft-like cystic spaces kind of all throughout. I think I'll zoom in a little bit. This area looks pretty good. Now we can get kind of a better feel for some of these almost tubular-like spaces. There's some here that look like they have more lumina. I'll zoom in a little bit more here. Okay, so now in these tubular structures, Somewhat round nuclei, a little bit pleomorphism in the nuclei. Some of the nucleoli themselves are prominent, kind of in the center of the nuclei. Okay, kind of follows that pattern up along here. Some of the structures look a little more solid, some more tubular, like I've said a few times. And then it looks like in between them, in between the tubular structures, we have these more eosinophilic cells. Let's see, cytoplasm looks a little bit different. I'm trying to get to a better area that shows those. Zoom out a little bit. I should have marked exactly where I was looking earlier. Okay, well, anyway, so I think the tubules represent some Sertoli cells, and then these cells that are in between the tubules look like Leydig cells to me. Again, we have to check the stroma and make sure it's just not plain fibrous stroma, but it does have a cellular component within it. So based on that information, I agree. I do think it is a Sertoli-Leydig tumor, as the diagnosis says up top. Okay, and that's what I got so far.
Okay, good, good. So one thing that, what are you looking for to verify that any of these stromal cells are truly Leydig cells?
Well, you could see crystals of Rinke in some of them.
Yeah, that would be probably the H&E sine qua non to make the diagnosis of Leydig cells. And if you were to use immunohistochemistry, do these two components have any different immunohistochemical characteristics?
They do. Like the Sertoli component would stain positive for WT1, while the Leydig cells would not.
Yeah, and so that's a useful stain in this situation to have available. It's not just used in serous carcinomas. This is another setting where the WT1 stain can be quite helpful, and using that to demonstrate the difference in these two components would be useful. Now, this is a variant of Sertoli-Leydig cell tumor, and that qualifier there, what makes this a retiform tumor, and why is that important?
Well, let me zoom out a little bit more. Some of these slit-like spaces, I'm not sure if that constitutes as part of the retiform classification, but it has a worse prognosis, I believe, than non-retiform variants of Sertoli-Leydig. Trying to find a good area.
Yeah, you're getting closer there. Yeah, those areas where you have this low cuboidal lining and more towards the right side of your screen than the center portion of your screen is more of the retiform type of morphology. And sometimes that should be generally more than 10% of the tumor to call it a retiform tumor. Because you could see maybe a minor component in a few areas and it wouldn't have the adverse prognosis. But anything that looks like a serous papillary lesion, or that has these very close anastomosing slit-like spaces rather than the rounded tubular structures here, the lower right there, that area is another area that's nicely retiform, this type of an area here.
Okay.
So those are the features that you see, and this is not a common architecture in Sertoli-Leydig cell tumors. So being aware of this variant, of course, can help you not call it something else, and then also classify it so that it gets the appropriate follow-up. Any questions for Jordan on this case, or for me? Okay, Rufe, you ready to go with the next case?
Sure. All right, case number 4. Looks like this is a section of, I'm assuming, ovary. although there's not a whole lot of normal ovarian stroma or anything left, but since we're in the ovarian section, I'm assuming that's what it is. But even at low power, you can see two distinct lesions. So right on top, you see more of a papillary architectural lesions with a little bit more complexity in terms of branching, a little bit hierarchical branching. And on the lower side of the slides, you see more of a relatively circumscribed lesions with somewhat a solid to cystic patterns over here, and maybe even some glandular patterns over there as well, but definitely cystic patterns over here. So if we look at more of this, a little bit more higher grade looking part of the tumors, you on the intermediate power, you do see some of the glandular formations in some of them. Looks a little bit complex over here. And some of the bluish hues, I'm assuming, looks more like a mucinous or pernicious secretions with a little bit of the artifact in terms of the retraction artifact over here. And if we look at high powers, the cells tends to be more round with clear cytoplasms with a variable size. Although the nuclei in some of these fields actually looks relatively uniform with oval to round nuclei, with some of them has a pretty conspicuous nucleoli. And if we look at some of those other areas, you do see there's a little bit of size variations. A little bit of eosinophilic secretions in the middle of the cells in a few of them. And if we look at the separate lesions over here, like I said before, it definitely seems to be more papillary compared to more of the solid and cystic appearance of the lesions below. And in terms of the papillas, you definitely see more of the complexities to it in terms of the branching. And you do see on some of these more columnar single layer, some of them are pseudo-stratified layers of epithelial cells. And if we go a little bit higher, maybe a few of them, I can see a little bit of cilia. So I think over here, the cells over here intervened by these fibrous and more of a spindle cell stromas with the solid and glandular patterns are probably a little bit more fitting for a clear cell carcinoma. However, though, I would assume this part of it actually looks a little bit more like a borderline to me.
Yeah, so it could be a combination of mixed serous and serous borderline and clear cell lesion. The nuclei in the papillary area, were those low grade or high grade? Would that be helpful to you? Or did you see any hobnailing of the cells or any particular hyaline change in the stroma? Because those are features you can see with the clear cell version of papillary architecture.
There's some hobnailing over here on a few of the papillas, especially over here.
Yeah.
It could be fitting, especially clear cell doesn't have to have a clear cytoplasm. It can have more of a towards the eosinophilic patterns.
Right.
It's definitely one of them. And also with some of the secretions, I think I lean towards more of that too.
Yeah, so this has a very interesting differential with the apparent mucin production in some areas. You want to make sure you ruled out mucinous neoplasia. The small cribriform and glandular pattern sometimes can be seen in yolk sac tumors, for example, although I think this patient probably much older age group than you'd usually see with germ cell tumors and so forth. And then because of the papillary architecture, you worry about the papillary serous lesions and so forth, or a combined lesion, as you've raised the consideration there. And in terms of immunohistochemistry, what's going to help you?
I think to me, like a PAX-A would probably be helpful. WT1 be helpful. P53 53 would be kind of helpful if we're thinking about this is more of a high grade serous on top. Yeah, those are the ones I probably will pursue first.
Well, you left off, of course, the marker that is most commonly used for a clear cell, which is napsin A, which is sort of an incidental discovery of a few years back, but has become quite useful in differentiating some of these ovarian lesions as well. And I think there's one other marker that we don't have in our lab that is even
HNF.
Yeah, yeah, yeah. In terms of prognosis and treatment, any of these lesions now, they're routinely wanting to know whether these patients are MMR deficient, and whether or not, in some cases, whether or not they manifest staining with HER2. And so those prognostic factors also enter into the discussion from time to time. Okay, Philip, you're up next. Take that next slide down on the rack and tell us about it.
All right. Let's see.
Case 5.
Yeah, I'm trying to get it to let me share my screen. Zoom. Why won't it let me? Let's see. Is it letting me share now? Yeah. Okay. So can you see?
Yeah, we can see.
Okay, good. So kind of the thing that catches your attention is this collection of cells over here. It looks kind of like we're in the hilus of the ovary based on all this stuff over here. So coming in, looking at this more high power, it's really cellular. There is kind of a lot of vasculature around it. When you come in and look at the cells, they kind of have this clearing of the cytoplasm. Some of them have kind of eosinophilic cytoplasm. The nuclei are pretty much all round. There's not a lot of atypia, though they do have kind of little inconspicuous nucleoli. So the differential for this, I'm pretty low on the differential, would be like dish germinoma, but I don't think it's atypical enough. And then the other thing would kind of be steroid tumor.
What about a metastatic tumor?
So it could be, I mean, it could be a carcinoid or something, and it could be a metastatic neuroendocrine tumor. Other metastatic tumors, I don't think that this is like a Krukenberg tumor. And there are other, I don't know of anything else that would really look like this.
Well, melanoma sometimes can give you a clear cytoplasm like this, but usually would have much more nuclear atypia than you have here. So
sure.
That was kind of what I was aiming at, just to make sure you always think of melanoma, as they say,
sure.
Because it can look like so many other things. So any markers that help you here?
Yeah, so if you were going to stand this up, you would probably do like an inhibin, a calretinin would be positive. MART1 could also be positive, which is a little scary with that differential.
Yeah, that's right.
But HMB45 would be negative, EMA would be negative.
Yeah. And are these tumors usually functional or not functional?
I think they're usually functional.
Yeah, not uncommonly, especially if they have estrogenic manifestations. This will be the lurking lesion that is fueling the hyperplasia or neoplasia in the endometrium or elsewhere. And so it's good to be aware of this and looking for these sorts of lesions. But of course, they can have other hormonal manifestations like ACTH and cortisol and so forth, just like any adrenal lesion that's active as well.
Right.
Any questions for Philip? Okay, Syed, you're next.
Can anyone hear me?
We can hear you.
Okay.
And now we can see your screen.
Okay, so so we have in this section we have actually two possible sections of the tumor here, and they have like two distinct areas. One are comparatively more basophilic or mixed eosinophilic compared to some areas that are lighter areas. And if we go to high power,
You must be on a slow OU computer. That's why it's not depixelating here. Give it a second. Well, we could probably count to 30 and we're still not there, aren't we? Siad, are you on an OU computer?
yes, I'm actually on computer, yes.
Why don't you let me share my screen here, and that we may not get that lag here. So I'll pull my screen. Oops, pull my screen up. So that we can go not bogged down here. Okay, so we're going to go to higher power in this area, and you can go ahead and describe.
I just have a
Okay,
black
so
screen.
I'm sorry, Philip, what did you say?
It's fixed. Never mind.
Okay.
so we have spindle cells like that are arranged in fascicles, and there's like fibrous bands of collagen in between, and the nuclei looks bland, and I don't see any prominent nuclei or any. There are some prominent nuclei in some areas, but not all the cells. And there were some areas actually when I was looking at, there were some areas that were comparatively granular cytoplasm. And so based on this morphology, I think Fibroma thecoma will be the most likely differential. And the other differentials could include granular cell tumor and massive edema, fibromatosis.
Okay, good. So just let's start at the top there. So what will distinguish between calling it a fibroma or a thecoma? Is there a meaningful distinction there? And if so, how do we make it?
So the cells are like, the thecoma cells can be leutinized.
Okay.
And or either they can possibly have a Leydig cell component to it as well. If we see the Rinke's crystalloid in those.
They can have steroid function of that sort, but really the distinction is largely a clinical one. Is there some clinical evidence of functionality? In which
so
case,
thecoma are like mostly like functional.
Yes, that's
and they will
correct.
have tumors.
Yeah.
And they could possibly manifest as endometrial carcinoma or other endometrial lesions.
Exactly. Now, there's one other lesion that might enter into the differential here, where you have sort of a nodular pattern like this, and less cellular and more cellular areas. Do you know what other lesion you should think about in that regard? It's less common by far than a fibroma or thecoma.
A fibrosarcoma or Krukenberg tumor?
Well, fibrosarcoma usually won't present in that sort of multinodular compassion or area with less and higher cellularity. What I'm thinking of here is what's called the sclerosing stromal tumor, which is a relatively uncommon stromal neoplasm, but one that has these alternating bands. But it's usually It's usually not quite as nodular as this. It's usually more vaguely nodular with intervening less cellular areas. And it can occasionally have signet ring cells and things of that sort to confuse you with Krukenberg tumor and so forth, which can also give you a lot of stromal fibrosis and have variable nodularity to it, as you've mentioned.
Okay.
Anything else you want to point out about this tumor?
Well, the immunohistochemistry is like positive for WT1, CD56, SF1.
Yes, your stromal markers. Question.
And I think that
This is maybe a board kind of question. Is this lesion ever associated with peritoneal fluid with ascites?
possibly not.
Well, never say never, of course. That's the answer. But actually, it is. There's a syndrome called Meigs syndrome in which you can get ascites and ovarian fibromas or thecomas. And so, just to be cognizant that just the virtue, usually you think of ascites with malignant lesions. This is a benign lesion that can have associated ascites. Okay, Beth, your turn.
Can I see my screen?
It's coming. Yes, there it is.
Okay.
Beautiful slide.
Ah, thanks. It's not mine. So from low power, I believe from the video, this is a normal part, and it's called the corpora albanacea. But this is what we are interested in. And as we go on higher power, we can kind of see these nest of clear cells. They look like epithelioid type cells. The cells themselves are uniform. They have a pale cytoplasm. They have small distinct nuclei, and right here we see some grouped nuclei. This was also pointed out in the video. This is a proteinaceous eosinophilic material that I believe is a remnant of normal tissue. We don't think it's metaplastic because we don't see any sort of invasion of the nests themselves. And it was signed out as a Brenner tumor, which is positive for CK7, thrombomodulin, and EMA, and it's negative for CK20. Differential diagnosis that I would think of is, I believe, I wrote it down somewhere. Insular type granulosa theca cell tumor can kind of look like this, but the staining would be a little different. And that's all I have to share.
Okay, so common question would be, does this ever come in a different flavor? In other words, can these be malignant, or is there such a thing as a borderline Brenner tumor? And if so, how would you distinguish that from what you have here?
I know there are borderline and malignant, and I think the last stage is the adenocarcinoma. I believe it has to do with level of invasion.
Yeah, and your cytologic atypia will highlight at least the borderline lesions. Will have some degree of cytologic atypia as well. Those are fortunately not common entities. Brenner tumors themselves are relatively uncommon, and those other flavors are far less common in terms of presentation and so forth as well. So, any idea where these come from? How do we get this sort of transitional type epithelium in the ovary? I
believe they come from the bladder. but I could be wrong.
Well, it's like the bladder. I mean, it's transitional epithelium like bladder, but is this coming from a teratoma, do you think? Is this a developmental remnant? Is it a benign transmigrating tissue like endometriosis and endosalpingiosis, or do we have any ideas on that?
It's a remnant. I believe it was a remnant.
Yeah, probably is something like that. Just like we have the Walthard rests in the serosa of the fallopian tube from time to time. These probably are derived similarly, and then you get some degree of growth and the stromal response related to that produces this tumor type lesion. Okay, very good. So I think we're back to Eleanor.
Okay. Okay, so here's number 8. So, low power impression looks like we've got kind of serial sections of the same piece of tissue.
Wait, share your screen.
Oh, goodness, I forgot about that. Okay, I believe I have shared. Let's see. All right, success. So sorry, serial sections of the same piece of tissue. And it looks like, again, or in the ovary, there's like sort of near the hilus, there's all these like blood vessels, and then this kind of like fibroconnective tissue. It's pretty large. And then we seem to have this, which is, I would think is probably our area of, going to be within our area of interest. So there's a little bit of what looks like remaining normal ovarian tissue. And then there's these handy black dots that highlight these nests here, which overall demonstrate cells that are kind of like tall columnar with these small round dark nuclei. They overall are like otherwise pretty bland, and they're forming these kind of like little tubules and nests. So this was called a sex cord tumor with annular tubules. And one of the important associations with this tumor is Peutz-Jeghers syndrome. So about a third of people who have Peutz-Jeghers, or a third of people who have these tumors, sorry, that's backwards, have Peutz-Jeghers syndrome. So if you like get one of these coming across your desk, you should either look for a history or see if that's being investigated for the patient. And then if we wanted to consider a differential, these can look a lot like granulosa cell tumors, so that's another one. Sertoli cell tumors and sometimes gonadoblastomas. In terms of stains, the sex cord tumors should be positive for inhibin and calretinin and CD99 and MART1, and negative for EMA, PLAP, and CEA. So that's what I got.
Those are important differential, those negatives, because obviously you would seriously consider things like a gonadoblastoma or a Sertoli cell tumor with that very clear cytoplasm and so forth in those tubular structures. You're going to be wanting to think about that. But you know, in reality, the low or intermediate magnification picture of this tumor is so characteristic. It's one of those things that, you know, if you just sort of have a knee-jerk reaction, you see it, you know it, and even though it's a rare tumor, it has such a distinctive morphology with these very delicate small tubules with eosinophilic center, and then the peripheral row of nuclei around each of those with the otherwise clear cytoplasm. So it's just very, very characteristic. Now, one quick question. We've got a big gap here in the slide here. So what happened there? Why do we have this artifact in the slide? And does that have anything to do with this lesion?
It looks like there's probably some chatter, probably calcification.
Yeah.
That's, I think, pretty characteristic of these. They'll get calcifications in them.
Yeah, they can calcify and cause other problems. And that's a clear sign of a microcalcification that got dragged across the tissue by the microtome and left a big gap in things there. So even the artifacts can be helpful to you in terms of knowing what kind of a lesion we're dealing with.
Cool. Thank
Great,
you.
Eleanor, thank you. So Carlos, I think you're next.
Yes, let me see.
Stop sharing, Eleanor.
Okay, second. So this one. Okay. So the next case, so we can see some areas, we can see at low power, there are a lot of areas of papillary structures that are within the ovary. At, well, something that we always want to see if there's any invasion at low power, and I don't think there is any in this case. And when we go high power, we have to look at the cytology. If we see any atypia, any mitosis, any stratification to differentiate, in this case, mostly from serous, that's the main differential diagnosis with benign, borderline, or malignant if there's invasion. So we can see some hobnailing pattern here at the tip of the papillae and some pseudostratification. And I think there's let me look at it. There's an area that is really characteristic. Let me find it. It's here. Let me see, when was it? Yeah, so we have this kind of villi that are really prominent. We have the papilla that are edematous, and we have the like this, the transient area between edematous papilla to delicated filiform papilla. So this is called caput medusae, and it has some criteria because we have to know if the pattern is either papillary or micropapillary, and we use a cutoff if the papilla are 5 millimeters longer than wide, and for invasion, in this case, we don't have, it has to be more than 3 millimeters area of invasion. But yes, I think there was an area like this area, more characteristic of this micropapillary pattern of the serous carcinoma, and in this case is borderline.
Yeah, you've touched on that important distinction between the borderline tumors, NOS, and borderline tumors with micropapillary architecture that may in reality and in many instances are deemed a low-grade papillary serous carcinoma. This is about as close. You've indicated that area where you've got papillae all the way around a small villus forming that medusa head or snake-like hair coming out of the central core. It's not really well developed here, and so I think this is a little bit of an iffy case in that regard. So yeah, would it stand up if you sent it off to Dr. Kerman or to any of a number of other more expert people in this area? I think they'd like to see more of this type of pattern than just what we have here before they really called it micropapillary serous carcinoma. So it's still a borderline tumor that has some micropapillary features and warrants further evaluation. Now, obviously, we don't make this call based on just one slide. and we want to make sure that we've very thoroughly evaluated the cases, the slides from and sections from the tumor, and that we've very well sampled, very thoroughly sampled the lesion, because as in any of these epithelial lesions, the serous, endometrioid, and mucinous especially, the invasive changes, the high-grade changes can be relatively focal, and you don't want to miss that. So you sample very thoroughly any areas that look different, any areas that have hemorrhage or necrosis or different features other than the standard papillary excrescences type of appearance. Any other questions for Carlos on this case?
I was just wondering, a lot of times these borderlines, like you mentioned, that you can have a papillary and a micropapillary pattern. It's almost like a mixture of it. Is there like a definitive like cutoff where you would lean towards one or another?
Yeah, so I would say a size greater than 2 millimeters of micropapillary change would make you sort of lean towards classifying it under micropapillary. And as Carlos said, the micropapillary changes usually would be along an extension that was 5 times longer than it was wide. So if these are in width maybe 1 millimeter, you're talking almost 5 millimeters of linear extent of that micropapillary change. Okay, Jordan, I think you're next. Back to you.
Okay, we can all hear me and see my screen, right?
Yep.
Okay. So not too terribly dissimilar from Carlos's slide. We have a pretty good cross-section, it looks like, of a large cystic structure. Let's see, we'll zoom in just a little bit. You can see there are some areas where the epithelial lining looks a little more like simple, if you will. A little more flat from low power, and then on other areas, a little more convoluted, some papillary structures here, pretty prominent right here especially.
Hey, before you leave low power, what do you notice that at low power that's different about this lesion than the other ovarian lesions we've been looking at? What's on the outside?
It has a capsule.
Well, no, that's not the answer I was looking for.
Okay, sorry.
What kind of tissue is that underneath the black ink?
Adipose tissue, fibroadipose tissue.
Yeah, so is that a normal component of the ovarian capsule?
Oh, no.
Okay, so that tells you that there's something funny here. Either this isn't from the ovary or omentum or something else was stuck to it.
Right, okay. Okay, let's see here. So let's keep zooming in. We'll focus on this not so pretty looking part. Okay. So as we could see from low power, it's very papillary structure, almost forming kind of village structures. But what we really need to look for is if there's any atypia, or how much atypia there is, I suppose. Let's see here. Now, I don't think there is any necessarily. Now, granted, obviously, these cells in the papillary structure look quite different from these ciliated cells down here. These nuclei are a little more round. These are larger, elongated, slender, little hyperchromatic. Yeah, so let's see here. As far as descriptions go, I think I hit all the pertinent findings, unless you'd like to ask me something specific, Dr. Hospital.
Well, yeah, low power on this particular area. Go out just a little bit, because I think you can see here that what's happening here is you're sort of pushing out towards the surface, and then you've got the fat that is still encompassed and encased it. So these lesions, even in the borderline category, can perforate and attract the omentum to try to smother or keep things in. Or if they perforate, then you can get these kind of implants in other areas that look like this. And I think this, even at low power, you can sense that this has a little bit more of that micropapillary type of architecture. So let's look at this area over, well, here right near the surface, and then above that, yeah, right just above there. So again, that's sort of the Medusa head of things going out on all sides, and then adjacent to it's the micropapillary change, and then moving northward again. A little further, a little further, a little further. Yeah. So here's where you could start to say, you know, is this 5 times as long as it is wide? Because this is a very micropapillary pattern here.
Yes.
And so this I think actually comes more fully into the category where you'd say this is enough fully developed micropapillary change to call it a micropapillary serous carcinoma or borderline tumor micropapillary type that has a higher recurrence risk and a potentially more aggressive course. Okay, let's see. Ruth, are you next?
Sure. All right. Are we on the 11?
Yes.
Yeah, we're on 11. All right. Actually, I was just looking at this. So this is another cystic lesion. You definitely see on the right side, you have quite a cystic areas with, I would imagine some of these almost excrescences on the gross description. And if we go on slightly higher power, the lining seems to be more columnar with intervening goblet cells, so it's more of intestinal type. Definitely have some of the mucin productions over here. Over on the other side, we tend to have a little bit more mucin and again, multicystic areas. The linings is a little bit more flattened, but you can still see the more of the mucin productions in the intervening like goblet cells. So if this was found in the ovary, I know that there's some of the structures over here looks a little bit complex instead of architectures, but I think it was just basically the nature of this particular neoplasm. It has a little bit of the crypt forming over here. So, and in terms of the nuclei, most of them are relatively elongated, not so rounded up. Some of them are a little bit rounded up with a not very prominent nucleoli. So I would say if this is probably a mucinous cystadenoma or mucinous, some sort of mucinous neoplasm, but I'm not quite gonna place this in the borderline category just because I don't see any kind of invasions and any kind of atypias just from the short areas we looked at, or not even that many mites, I don't think.
Yeah, so this is a challenging area for classification, of course. And if you were seeing this on frozen section, you know, the most important thing is to tell the surgeon it's a mucinous neoplasm, and it's not just a simple mucinous cystadenoma. So it's at least borderline is where you're going to go with that. And if you've got some necrosis or something like that, oh, that's going to, you know, if you don't have torsion or some other cause to explain that, then you'll be even more concerned for malignancy. Not unlike the serous borderline tumors, when we start to get this degree of sort of villus formation, we've pretty well moved then into the borderline category. So seeing this degree of architectural complexity in a few glands would push us to say that it's at least borderline. And then there are kind of a few little steps further. So you can have borderline mucinous tumors with intraepithelial carcinoma. So you can actually have varying degrees of dysplasia or otherwise that can begin to look like carcinoma in situ, or high-grade malignancy, or clear-cut malignancy at least, that would fall into that category of mucinous borderline tumor with intraepithelial carcinoma. And then the next step would be microinvasion, meaning you found it in just a 1 or 2, less than a millimeter, one or two high power fields or something like that. And like I said previously about the other lesions, this is one of those tumors where the changes can be quite variable from one field to another. And you nicely illustrated that when you looked at the more necrotic area where the epithelium is all smooth and rounded out around the mucin and so forth, and there's no architectural complexity, versus on the right side, we've got all this complexity. And so sampling these tumors, at least 1 section per centimeter, is appropriate to make sure that we don't miss those foci of microscopic invasion or in situ neoplasia or something like that. In order to qualify one of these mucinous tumors as a mucinous adenocarcinoma, you need to find clear-cut evidence of invasion. Unfortunately, there are sort of 2 patterns of invasion, one of which is fairly easy to recognize, and the other of which is relatively subjective and can be therefore quite complicated to recognize. So the destructive sclerotic type of invasion, pretty easy to recognize. The pushing pattern of invasion, much harder to recognize. If you go back out to a little bit lower power, the distinction can be that, as you'll see with much of this tumor here, it has sort of a stroma to it. It has its sort of own, slightly cellular stroma, sort of like endometrium has a stroma. Well, these mucinous tumors very often have their own characteristic, slightly blue stroma. And when you have pushing invasion, you tend to be pushing beyond that into a more eosinophilic stroma. And so that's kind of that's what defines the pushing invasion pattern. Now, another pattern of invasion that sometimes can be seen is actually sort of mucinous colloid carcinoma, mucin pools with neoplastic cells in it. But what happens more frequently is you get, like we have here, you have mucin pools, but no epithelium in them. It's just inflammatory cells here. And so this is not mucinous colloid carcinoma. This is just acellular mucin that has dissected for whatever reason into the stroma and produced an inflammatory response. Well, I feel like we're cheating out Philip and Beth. Do you want to go and do 2 more cases, or should we stop here? And Syed, there's 3 of you that didn't get a second chance.
Actually, Dr. Hassel, I have a quick question on this case too. So
Sure.
You mentioned that some of these architectural complexities to it. I understand a frozen, it probably does look really scary. But on this though, I thought some of these are more of a cribs of the intestinal type. And from what I was reading, I thought those are, I don't know what percentage is allowed, but I thought there's a certain percentage that's allowed to have, for the mucinous neoplasms, you're allowed to have these crib-like formations and still not put it quite in the borderline or the higher categories. I was just wondering if there's like a little cutoff we can use to say the complexity is a little bit higher and these are beyond like just the crib formations.
Let me get back to you on that, Rufe, because I have not used any specific cutoff for that. If I generally see, if I see more than two or three of these cystic spaces that have a villus architecture or an upward extension of the mucinous epithelium, that usually moves me into the borderline category. But I'll double check and see if I'm using the wrong criteria on that and get back to you.
Thank you.
What do you think, Philip? Should we stop?
We could stop, or I could do one. It's up to you.
Oh, why don't you do one? I think with the next one's a good case. So let's do one more case, Philip.
All right. And you can see. Okay. So here we've got, you know, proliferation of cells. I think over here is kind of just like a not part of the tumor, but I do think that this is some like endometriosis over here.
Great pickup. Important thing to note. Yes, very good.
So we've got this tumor. There are foci of necrosis floating around. It's pretty much all solid with kind of just intervening stroma. So on higher power, you know, there's some atypia, there are nucleoli, there are mitotic figures. I don't think that's one, but there are some floating around, kind of vesicular chromatin. So you would have to kind of approach this with a wide differential, but I think endometrioid adenocarcinoma high grade would have to be in there. It doesn't really look like serous to me. What else? I think those would be kind of the big things. So I would go ahead and stand. I guess it could be, what was the first one we talked about? The adult granulosa cell tumor, but it doesn't really look quite like that either. So I would go ahead and stain this up, Vimentin, P16. I guess I'd get a P53, ERPR, and WT1 and Paxate.
Yeah, so conventionally, the morphologic features that help you to classify something as endometrioid would be any evidence of squamous differentiation, and you just passed over some of the features that might be there. This sort of necrotic area may be sort of a granulomatous reaction to keratin.
Okay.
And so sometimes that's a soft finding. And then the other thing that you picked up right away was the evidence of a background of endometriosis, which is present in a high proportion of endometrioid carcinomas. But then you're going to, in this day and age, you're going to use immunohistochemistry to verify your diagnosis and so forth. And especially in the grade 3 endometrioid tumors, the differential with serous carcinoma is probably the major differential. And the markers that you indicate, of course, would be important. Again, in endometrioid carcinomas, they're going to be interested in, does this patient have Lynch syndrome? You know, or are they MMR deficient, mismatch repair deficient? And so those factors, again, come into follow-up treatment in these patients as well.
Yep.
Okay, hey, very good session today. I appreciate your coming so well prepared, and I think allowing you guys to drive the slides worked really quite well. And we'll look forward to doing this again. I've still got a couple of short lectures to post on the common epithelial tumors. Actually, I have 2 more lectures, so look for those videos. I'll try to do much with those as I have with the other 2 that are the less commonly encountered lesions. But obviously, you did your homework, and appreciate the chance to spend the hour with you. And have a good afternoon.
Thanks, Dr. Hassel.
Thank you.
Thank you.
Thank you.